evening. Welcome to Aster CMI Facebook Live. Today we'll be speaking on surgical aspects of breast cancer with reconstruction. We have Dr. Girish G, consultant surgical oncologist, and Dr. Madhusudan G, consultant plastic surgeon, and myself, Mahesh MS, plastic surgeon. Today, February 4th, considered as International World Cancer Day. And we chose the topic of surgical aspect of breast cancer and with the reconstruction. International World Cancer Day. Girish sir, what are the significance of this day and what is the theme for this year's Cancer Day?
World Cancer Day is recognized by about 64 to 70 countries. They all officially recognize this day as World Cancer Day to raise about the awareness in the people regarding this aspect. Awareness is the most important part of cancer treatment, because unless awareness is there, people don't come or seek advice for their treatment. They neglect and probably they come at a later status. Early diagnosis and treatment being the important part of the prevention and the treatment is not at all reached in such scenario. Hence, the awareness is the most important aspect of cancer care. So about 22 years back, few countries joined and they brought about this concept of a World Cancer Day, though I don't know the exact reason why it is February 4th. So since that time, every year with the theme, this has been worked upon that people would be better made aware of such cancer itself and its treatment options available. The present year's theme, that is 2022 theme, is Close the Care Gap. World over, populations are different in all aspects. People are poor, rich. Even if they are rich, they are not aware, they don't want to seek. Poor countries, they probably would not be able to be providing as a comparable service to other countries which are better off. Within a country like India itself, different states and different capitals have different types of cancer care facilities available. All people would not be having access to the best available services. So, from each and every aspect of the person who is being involved in cancer care, right from the treating doctor, to the person who is involved in the laboratory medicine or in the hospital or the government services or the social services, family health welfare services, they all should strive and make sure that all of them, regardless of socioeconomic status, should get equal appropriate opportunities for the proper cancer care. This is the theme which has been worked upon for this year.
Sir, among all the cancers you see in OPD, how much of them, how many percentage of them are usually breast cancers?
Yeah. Probably I would say this one is the maximum, including both sexes, both males and females. Breast cancer is the most common one which we see. Every third patient is probably a breast cancer lady. She comes with a history of breast lump, and probably not all breast lumps are breast cancer, but every third patient I would consider which we see in our body would be a breast cancer patient.
For the benefit of the patients and the general knowledge, what are the modalities of treatment available for breast cancer?
Any cancer for that matter involves any solid malignancy, involves all aspects of treatment, that is surgery, radiation and chemotherapy, which includes target therapy and other varied options available. In a patient who is supposed to be treated with a curative intent, other modalities are usually used to reach that the patient will be used, or used to see that the patient will reach a stage wherein surgery is possible, or surgery for an early stage will be done later on, sent to the medical and radiation oncologist for radiation and chemotherapy. So it is basically surgery, radiation and chemotherapy. All these things are based or used based upon the stage of the patient, stage at which the patient presented, probably after chemotherapy or after neoadjuvant treatment, what it turned out to be, and final histopathology reveals the final stage, what would be the appropriate treatment for that stage will be decided upon.
What are the different kinds of surgery are there for all these different stages of the breast cancer?
Breast usually has to be only of two types. We're talking about malignancies. The earlier surgeries, or I would say more than about 20 years, would be commonly be something called as modified radical mastectomy, wherein regardless of the number of lesions present in the breast or the size, all patients appropriately treated by chemotherapy if required would be subjected to complete removal of the breast and the lymph nodes of that area in the armpit. So that would be called as modified radical mastectomy, wherein the lady had to forego whole of her breast, including the nipple areola complex also. As the chemotherapy and the newer modalities of treatment came up into picture, including the targeted therapy, with the common availability of immunohistochemistry, all those things. Now the trend, or with the available evidence which is appropriate and proven, something called as breast conservation surgery is the most commonest one, which is usually preferred by the patients. Here the lesion with an appropriate margin is removed, and then the uninvolved part of the breast is retained, and the nodes in the armpit are taken care as in case of any other breast surgery. We commonly use something called as sentinel node biopsy along with either MRM, that is modified radical mastectomy, or breast conservation surgery. So armpit or the lymph node management in the armpit would not vary. Only thing is that the uninvolved part of the breast would be retained in this breast conservation surgery. So the nipple areola complex, or sometimes the nipple areola complex part of it would be removed, but most of the uninvolved part of the breast would be retained. It would be called as breast conservation surgery.
So there is a question from the viewer. How do you reduce the risk of getting breast cancer? I am a mother of one kid, aged 35 years.
You don't have any risk reduction medicines or any specified protocols that you can reduce the risk. No one would be probably mine now. Appropriate healthy lifestyle might help us, but there is no absolute thing that you take this or you do this and you will definitely not be having a breast cancer. No, that is not available. Just that you might be coming to us in an earlier stage only when you examine yourself and found to have breast lumps. That might be helpful. Or the classical screening programs, including the X-ray mammography, which is advisable after age 40. These are the things available. Otherwise, as what I understand by your question, that you do something or you avoid something and then probably you don't have this breast cancer. No, I don't think so. Such specific medications or any chemo prevention drugs are available. Just a few things that breast lactation at an early age, so that the maturity of the breast epithelium occurs at the early age, might be helpful, and probably if there is any known family risk factors, so that you get yourself screened at an early age, or probably get physical examination by a physician at an early aspect, then probably that would be helpful. Otherwise, other specific things that will be preventing breast cancer.
So early detection is
early diagnosis and treatment is the thing, and screening is definitely available by X-ray mammography.
So do all these cancer excisions require a breast reconstruction, or whom do you select that this patient requires a reconstruction?
It probably depends upon the size of the breast and the part of the breast which has been removed during the surgery. And regardless of all those things, we offer reconstruction options available to the patients, that plastic surgeons are available in-house and variety of surgeries are available for reconstructions. And probably they decide upon after meeting the appropriate surgeons here or colleagues here. So if at all the breast size is small and the excision involves a larger part of the breast to be removed, then probably she would be an appropriate candidate. Regardless, if the breast size is large enough and probably a small part of the breast is lost during this breast conservation surgery, then probably, as we discussed, she might realize that she may not be adding much to her confidence by retaining or getting the breast reconstruction. Then it's up to her to just stay like without reconstruction option. Otherwise, anything which causes an asymmetry in comparison to the opposite breast would definitely require a consultation with the plastic surgeon for appropriate reconstruction.
Madhusudan sir, the commonest question among the patients or age group of these ladies, they have one question is, am I a good candidate for breast reconstruction? So, who are all these candidates following the excisional surgeries or a candidate for breast reconstruction?
As Dr. Girish told now, when the major part of the breast is removed and compared to the other breast, and definitely they would be a candidate where immediate reconstruction will give us a better outlook for the patient. We could say that especially when there is a MRM done, modified radical mastectomy, where the disease is progressed, where the breast conservation surgeries are not available, not possible in that case, and most of the breast is removed with a part of the envelope or part of the nipple envelope complex. These are the patients who require breast reconstruction. But there is something called oncoplastic surgery, where we use a little bit of chest wall based small tissue transfers or movements to make the symmetry possible. So, depending on the amount of the loss of the breast tissue, there is varied amount of reconstruction surgeries are possible.
The next question in their mind will be when this surgery will be done. That means the timing of the surgery. Will it be done immediately following the excisional surgeries, a month later, or 6 months later? When it is done, the timing?
Actually, it depends on the disease. Most of the patients who undergo surgical treatment for breast cancer, most of the time it will be curative surgery, or they will go for a preoperative chemoradiation followed by surgery, or surgery followed by chemoradiation. In both the cases, immediate breast reconstruction all over the world has given the best results. Unless until there is a chance of the margin involved or the patient has advanced breast cancer, where the surgeon and the cancer surgeon would like to wait even after the surgical treatment and the complete clearance of the disease, then we should do a delayed reconstruction. Otherwise, the immediate reconstruction of the breast is the treatment of choice.
I think even after immediate reconstruction, the mental status of the patient will be better, because even soon after out of anesthesia, there is the patient won't feel that she has lost something. Something is there in that part. So that will also play a role.
Because what we call is now organ conservation in all cases of cancer surgeries, be it head and neck, breast, it can be any other part. Other organ conservation is the goal ahead. So wherever there is a possible of breast conservation and giving the equal results is always better. But when there is a chance of reconstructing the organ, it's always you should give a chance to the patients for doing a breast reconstruction.
I would like to say that here the awareness of the patient is important. Her outlook of herself is more important. The patient should be aware that this is my body. It would give confidence to me to look around. People may be okay without the breast also. That's different. That's still higher level of confidence, I would say. But when a lady comes to your OPD or before she presents to you, that these such things are available that can be done regardless of your financial liabilities. Definitely these things are possible.
There is one question from the viewer. How many surgeries are required for breast reconstruction? Probably she wanted to know what are the types or how many stages it will be done.
There is only one stage reconstruction in breast. There are varieties of breast reconstruction depending on, one is the volume of the tissue to be replaced, and second is the choice of the patient, what type of the tissue they want to get. Third will be the availability of the tissues in the particular patient. So the smaller defects, like when we classify the breast into 4 quadrants, there's only quadratic defect is there, where we can use a neighboring chest wall based flaps, movement of the skin as well as the fat tissue can itself give the adequate amount of reconstruction, especially in a smaller breast where the excision also much smaller, and it will give almost a symmetry compared to the other breast. So there are variety of chest wall based flaps are available, which sometimes are done by onco surgeons also. Sometimes plastic surgeons also are involved in this kind of oncoplastic surgery. This is one level. Second is when there is most of the breast is removed, where we have to replace both the skin as well as the volume of the breast. We have two standard surgeries. One is an implant based reconstruction, other is an autologous tissue transfer. So in the implant-based reconstruction, the volume of the breast is replaced by an implant, and that will be covered with a muscle which is transferred from the back. Latissimus dorsi muscle is taken from the back and it is swung over the breast tissue, and under the muscle the implant is put. So it will give the volume. That is the implant-based reconstruction, which is also done soon after the surgery. And second thing is autologous tissue transfer. So most commonly the autologous tissue transfer is based on the skin of the abdomen, lower abdominal wall, where there is adequate skin available with the amount of soft fat, which almost resembles the breast in most of the situations. Loose, fatty, lower abdominal fat and skin is an ideal replacement for a breast tissue. This is done. This is called a DIAP flap. This is done as a microvascular surgery, where an amount of tissue which is to be replaced are transferred over a arterial and venous pedicle, venous anastomosis, which is done to the chest wall. So this is as a microvascular surgery, the breast reconstruction are done. It is one of the most commonly done autologous breast reconstruction. In some patients who are already undergone some surgery in the abdominal wall, like hernia or repeated scissor sections, where the abdominal the blood circulation to the abdominal wall is already been violated, where we cannot have, because this amount of tissue to be transferred over a perforator, the small blood vessel on the abdominal wall. If that we feel that the abdominal wall perforator is not good enough, we can use the tissues from the inner thighs, or we can use the tissues from the buttocks. These are the other two donor sites from where we can transfer the autologous tissue to make the breast. So these are the view, like one view of these three varieties of breast reconstruction.
Any risk associated with breast reconstruction following excision? That is the next question.
So risk is that there is an increasing operating time. That's the only thing. It depends on the patient general condition. If the patient is a fit patient for a breast excision surgery, an additional 3 to 4 hours, depending on the type of procedure we are going to do, will be needed for additional reconstruction. And if the patient has no other comorbidities like a heart diseases or elderly patient where the prolonged anesthesia is carrying a risk for the post-operative chance of developing any heart attack or any other complications, that patients we can
I'd like to add that whenever reconstruction is done with respect to either autologous transfer or usage of implants, it has been proven beyond this thing that it should not be a problem for further continuation of follow-up with respect to clinical examinations or usage of other investigation to regularly follow up of any recurrences or metastasis. So that should not be a cause for concern.
in fact, having one more vascular tissue of that area will be helpful for the radiation or the chemotherapy, because it's going to have a better penetration, tissue penetration from the radiation of the chemotherapy, because increased blood supply to the localized area.
So reconstruction doesn't interfere with any chemotherapy or radiotherapy.
Oh.
Unless there is a wound problem, it should absolutely be of no concern at all.
One more question is, how
It all depends on how the breasts are before the surgery. There's some breasts are if they're already sag and there's a lot of loss of volume in the other side, other breast. the reconstructed breast would look much more tighter than the other breast. Sometimes the patient would like to get the other breast also modified to the reconstructed breast. Otherwise, if you use the implant-based reconstruction or with the abdominal fat skin, which we use as a day flap, both the feeling of the breast is also like the other breast only. And only thing is that nipple areolar complex may not be reconstructed at the same time. If in the original surgery of the cancer, if the nipple areola is removed, then that will be done as a later stage. So that is a cosmetic part of it, which we can be done after about few months.
Will there be any changes that happens over the reconstructed breast, or will it require a secondary procedure during the age, or if the patient gains weight or lose weight, will there be any changes in this reconstructed breast?
Most likely not, because this reconstructed breast may not sag to that level as the usual normal breast sag. Only secondary surgeries required is, as already mentioned, we might require about nipple areolar reconstruction, which usually done with the areolar reconstruction done with some tattooing, and small nipple reconstruction are done with a very small OPD procedure to make a nipple, which will give the symmetry to the both breasts. Or sometimes other breast can be made symmetrical to the operated breast in some cases where there is a sagging of the other breast. Other than this, then there will be no other need of any further treatment, and if the patient gains weight or not, that doesn't have any increase in the breast size.
With radiation, do you think there will be any change in the reconstructed breast, or usually you overdo sometimes to see that after radiation it comes to a symmetrical opposite side, or you just see that it will be symmetrical on table with respect to the opposite side?
No, we cannot do a overdo reconstruction considering what happens on the radiotherapy. Only thing is that after discussing the patient about seeing the other side breast, is there any symmetry which you can achieve? And only that is the reference point for us to make the volume reconstruction. There may be some chance of hardening of the fat, there may be some kind of a fat necrosis that can happen during radiotherapy, but that is not a very great extent. And that will all come back after recovery from the radiotherapy, and most of them don't feel that is one important problem that they suffer from.
Will an implant-based reconstruction, for example, an LD flap has been done and an implant has been put, will there be any interference with the radiotherapy? Will there be any capsule contraction or anything? Or will it be?
Implant-based reconstruction, there are advantages and disadvantages. One is that it's a simpler procedure compared to the autologous breast reconstruction, where it takes a little longer duration and needs a microvascular expertise to do the transfer of tissues to the breast. But implant-based reconstruction is simpler. It can happen within 2 hours after the surgical removal of the breast, where the implant has been put and a muscle will be transferred from the back to the front. And definitely these implants are not going to hamper on the radiotherapy, but there are speculations that the saline-based implants has been used, and the saline has been evacuated and make sure that the radiation penetrates back into the chest wall better than having an implant. But nowadays it doesn't have that amount of any significance. And I just want to know from Girish also how you feel about implant-based reconstruction post-radiotherapy, anything you have seen?
I personally have no experience about this implant-based reconstruction for malignancies. So, but whatever has been known is that they have no role of, no significance with respect to adjuvant treatment, including radiation or chemo. So it should not be a problem.
One thing I would like to say that there are some cases of secondary anaplastic carcinoma cancers developing in a textured implant being used in breast reconstruction surgery, especially post-cancer breast reconstruction, where the implant is textured. Such an implant which has been used, and they are known to develop the cancer along the capsules as anaplastic carcinoma. That has been recently been reported in the Western also. That's one thing I think we are going to go ahead and see, that where the textured implants are not going to be used anymore, because smooth implants is used if at all. That's where we have found it over the period of 1 or 2 decades. We have found out that the textured implants are associated with increased risk of developing anaplastic carcinoma. So now the smooth implants are the ones which are good.
I think you have answered most of the questions. Sir, would you like to tell someone something to all our viewers from International World Cancer Day?
I think I already spoken actually. Just that awareness and seeking treatment at an early stage is the most important aspect. Everything is available. Only thing is you need to come and seek it out. Whether I'm not telling that it is just Aster Hospital or anything. There are people everywhere. Each and every district in India has an appropriate care person there available. So neglect should not be there. When you know things, you should definitely tell it to other people. See that they go seek advice and get treated at an early stage so that you can definitely think towards getting cured of. As the stage progresses, the chances of cure come down. So all of us should strive such that people know about this and they get easy access regardless of their socio-economic status to appropriate care.
Because breast is the thing which the patients will always be having a little stigma of going and seeking a doctor's advice, exposing and showing them. That's the one thing which happens, especially in very conservative background people, and they are the people who come late in the disease, and they end up in losing their lives. That's where I think, as Dr. Giri said, it's one awareness is very important in cancer, because earlier the cancer stage is better for everybody, and the treatment is simpler, the duration of care, treatment is easier, simpler, easier, and cost effective, and the results are fantastic. The lifespan is better, the cure is, the 100% cure is possible. So I think the awareness, as he says, the awareness is very important, and as this year's goal goes, then there should be unity, there's a complete, the equality in the care, irrespective of the place where the patient belongs. So I think that all we have to go.
One thing that I add, ಕೆಲವರಿಗೆ ಅವೇರ್ನೆಸ್ ಅಂದ್ರೆ ಅರಿವು ಇರುತ್ತೆ, ಅರಿವಿನ ಜೊತೆಗೆ ಭಯನೂ ಇರುತ್ತೆ. ಅಯ್ಯೋ ಹೋಗಿ ಏನ್ ಮಾಡ್ಬಿಡ್ತಾರೋ, ದುಡ್ಡು ಖರ್ಚು ಇನ್ನೇನೋ ಮಾಡ್ಬಿಡ್ತಾರೆ, ಇದನ್ನ ಕುಯ್ದಾಕ್ಬಿಡ್ತಾರೆ, ಹಾಗೆಲ್ಲ ಯೋಚನೆ ಮಾಡಿ ಬೇರೆಯವ್ರು ಇನ್ನೆಲ್ಲೋ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಗಿರೋರ್ ಹತ್ರನೂ ಕೇಳಿ ತಿಳ್ಕೊಂಡು ಇಲ್ಲ ನಮ್ಗೆ ಇದು ಬೇಕಾಗಿಲ್ಲ ಅಂತ ಅನ್ಕೊಂಡು ಭಯ ಪಟ್ಕೊಂಡು ಮನೆಯಲ್ಲಿದ್ದು ಅನುಭವಿಸೋರು ಬಹಳ ಜನ ಇದ್ದಾರೆ. ಸೊ ಭಯ ಬಿಟ್ಟು ಏನೋ ಆಗೋಗ್ಬಿಡುತ್ತೆ ಅಂತ ಹೆದರ್ಕೊಳ್ಳೋದಲ್ಲೇ ಅರಿವಿದ್ರೂ ಕೂಡ ಭಯ ಪಟ್ಕೊಂಡು ಮನೇಲಿ ಇಟ್ಕೊಳ್ಳೋರು ಬಹಳ ಜನ. ಸೊ ಅರಿವು ಅಷ್ಟೇ ಇಲ್ಲ, ಭಯನ ಬಿಟ್ಟು ಬಂದು ತೋರಿಸ್ಕೋಬೇಕಷ್ಟೇ ನೀವು.
No new questions.
I think,
Yes.
can we conclude?
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you.
Thank you.